What is the Penn Medicine Nudge Unit? It's the world's first nudge unit and behavioral design team embedded within a health system. So what's our mission? Our mission is to leverage insights from behavioral science to design, implement, evaluate, and disseminate scalable nudges to steer medical decision-making towards higher value care, improved patient outcomes, and more equitable healthcare delivery. So I'm just going to highlight a few examples from our recent work. So this is a request for proposals project brought forth by a team. Primary care is trying to improve medication adherence. And actually, there's a financial incentive to improve that. When you survey patients, one of the biggest barriers is having to go back to the pharmacy every month to refill your prescription that you should just be taking around the clock. And it turned out there was some variability in the prescriptions. And so what was done was that in the preference list, which is the list that clinicians order their medications, we changed the default to 90 days with 3 refills. And basically, right after Thanksgiving, that was implemented an overnight boost from about 70% to 90% for a prescription that's ordered over 140,000 times a year in our health system. Another project this was submitted, and we're supporting this, Rebecca Ham, who's an incredible OBGYN implementation scientist. She had previously validated a calculator that, when implemented, reduces unnecessary C-sections in low-risk patients, and then for patients that are high risk, it prompts the clinicians to actually move forward and do the C-section and avoid complications. The issue is that it existed outside of the electronic health record. You had to, remember to do this and go to a website. So we worked with our informatics team to actually build it directly into the default workflow on labor and delivery, where we actually developed a column right in the workflow, automatically would prompt clinicians to say, this patient's eligible for this calculator, and then it would automatically calculate it, and then we developed prompts for the clinicians to discuss with patients. And so this is ongoing work right now. I'm just going to say it's wildly effective. It's going from 0% implementation to at least 60 to 70% implementation. This is an example of some of our grant-funded work. We're trying to work on right-sizing postoperative opioid prescriptions. What we basically found out in our contextual inquiry and talking to surgeons was one of the biggest barriers to prescribing less after surgery, say knee arthroplasty, is that they're concerned that their patients would be in a lot of pain. And there was really no sort of set guideline for what patients should get. So we first did this Learning Health Systems initiative where we started automatically texting patients after surgery to find out how many pills did you take. We then developed clinical guidelines and implemented those guidelines. And then because we're getting this data continuously, we then started feeding it back to the clinicians, and we did peer comparisons. What we found was we implemented this in the system in the step wedge trial. It boosted medication guideline adherence from 45 to 70%. It reduced the number of pills prescribed for these 30 procedures by 25%. So we're talking about literally hundreds of thousands of pills. But importantly, because we're continually collecting text messaging data on their patient-reported outcomes, their ability to manage pain remained the same. This is work in collaboration with Maggie Lowenstein, who's an addiction medicine physician, and then one of our emergency department nurses, Rachel McFadden. We wanted to make screening and treatment in the emergency department for opioid use disorder the default. So we went into this and said, okay, we're going to have a pop-up alert. It's going to just identify people based on the chief complaint. But when we actually talked to clinicians, I don't want more pop-ups. And so we did the focus group, and it turned out the nurses really wanted to do something about this. And they were empowered, and actually, they were willing to just ask the question in triage. And we pilot tested the question. And now it's default practice. Over 97% of our patients get screened. And then we know with 100% specificity whether the patient is actively in need of help. And then we could target both prompts to clinicians and nurses. And so basically overnight, we're able to increase the proportion of guideline recommended therapy for patients by 23%, and then sort of scale this throughout our health system. Lastly, a sample operational partnership with the Opioid Task Force. Another issue that we've sort of found out is that for opioid prescriptions upon discharge. We could provide all these guidelines. We could try to change individual preference lists for different departments, but if there wasn't a preference list, there's this background default. And it turned out that in the background, that default was 28 pills for prescriptions. So we just changed the default after clinician buy-in from 28 to 15, and basically an overnight shift in that prescription amount to 15. And the last layer to this is just in the backdrop of all this, I work in the emergency department. I had some really tough shifts this weekend. People are burned out. It's just the fact of the matter. And behind all this just came out yesterday. New data sheds light on the gender gap in physician burnout. So 57% of female respondents said they had burnout, 47% of males. And this is everything that we do in trying to get clinicians to deliver more evidence-based care has to be balanced with where people are right now and clinician well-being.